Hi everybody, here we are going to present another case that we did at the recent WCUPS live surgery program in May 2024. The case that we have done will be presented by Dr. Tommy Park, Jonghwa Tommy Park from Singapore, who I had a great time in Vietnam together. The case was a young female patient who had the tooth upper left central incisor luxated 4 days prior to our program date. So there's no other treatment but an accident that knocked that tooth out. Fortunately for her, the adjacent teeth were in fairly decent shape and did not require any other treatment. There was no major bone or soft tissue defect, and the socket was left fairly intact. But unfortunately, the patient had periodontal disease and poor home care with mildly spacing, as you can see in the incisors. Therefore, malocclusion was evident. We were fortunate to have CBCT. Not all cases had this luxury at this program, but this is a CBCT that is representative of this patient. Notice the big difference here. In clinical reality, the patient is eccentric and looks like an Angles class 1 type of an occlusion, but the CBCT shows otherwise. And that is because the CBCT was taken with a bite fork, as you can see in this cross-sectional view. This is a very poor habit that we all tend to have. This is another case that I did not too long ago of a patient. The patient actually is a dentist in the United States. He had this incisor endodontally treated and then ultimately fractured, so I had to place a single implant for him. But take a look at the arbitrary image of the CBCT taken on the left side with the bite fork, and the one on the right, which I retook, which I call it the real bite, eccentric or habitual bite. Why is that important? Is because when we do the actual implant planning, this is the same case. I want to figure out what size implant to put in where, what trajectory, and occlusion and the opposing teeth have a lot to do with it. So here I have managed to put all the data together and figured out the exact proposed position, dimensions, angulations. All of these were pre-worked up. But the important thing is I need to know where the proposed tooth will be, and therefore the implant position works with that in mind. And in this case, with all that careful planning, as you can see, the completed case, a screw-retained central incisor that has the right embrasure form and beautiful soft tissue that's being maintained in the papillas and all of the important cosmetic criteria, but that was all due to very precise implant placement, and that all starts with good review of the CBCT. When the CBCT is taken with a bite fork, it adds a number of layers of burden to us because there's really no good reason to do this. Initially, when CBCT was relatively new, we basically got into the habit of doing this. For more information on this, I have another video online on taking the proper CBCT. For the sake of time, I would like you to refer to that. But this is just not realistic. Basically, what we have learned from this case, we wanted to not flap the facial. As you can see on the CBCT again, the facial bone is very thin or almost non-existent, and there seems to be somewhat of a fenestration defect somewhere on the facial buccal plane. And because of that, we decided to not flap the area if at all possible. So the first thing we had to do is debride the socket, and then we are going to start the osteotomy very carefully, looking at all the anatomical parameters very carefully. And this was our final position of the osteotomy that we all agreed was fair. From a mesial distal point of view, this is simple. It needs to be simply in the center. but how far facially or lingually, palatally, we need to angulate or bodily move it facially or palatally is a big question. The simple hint is to put a imaginary tooth. In this case, because the teeth were in good alignment, we simply had to imaginary, duplicate a tooth there. And we wanted the implant trajectory to come out slightly palatal to the incisal edge. So schematically, this is a way to understand it. This is the pre-op CT. This is the proposed restoration shape, and this is the proposed implant position based on that, which means the implant is going to go into the palatal aspect of the socket, leaving somewhat of 2, maybe slightly more than 2 millimeters of facial gap, which will be filled with biomaterials to allow regeneration of bone or hard tissue in that plane. So that is the long axis, and according to that long axis, that should provide a cingulum screw access hole. Whether you do screw cemented, it doesn't really matter. You really want that to be over there for a number of biomechanical and biological reasons. So hence, this is the result that we celebrated. Now here on just my keynote, I've simply copy-pasted the existing tools and replicated in mirror image, so that looks like that's a very sound position. So let's look at what's going to happen when we place the implant. The implant, as we have planned, will be a 4 millimeter by 13 millimeter. We want it as long of an implant as possible to engage into the palatal bone, and that's how we get primary stability. And this was the final position of the implant based on our implant mount. And as you see very carefully now, the implant seems to be a little bit more facial. So let's take a look at this carefully. When the osteotomy was done, the long axis was lingual to the incisal edge. But as the implant was placed, it actually ended up right at the incisal edge. So what did happen? Well, let's try to understand this schematically. This pink represents the initial osteotomy that we worked very hard to get. We worked on the slant. We worked with a number of drills, piezoelectric surgery, and so forth to get that anchor point, and we drove in the small diameter twist drill until we got to the final twist drill. And then once the implant is going into that trajectory, what tends to happen is it tends to go in fine initially, but as the implant goes in more apically, it starts to hit the palatal bone. And the palatal bone is dense, and therefore it will provide some resistance and actually end up twisting the implant so that the implant changes direction and trajectory. So this was the original intended trajectory, but the implant possibly will end up in an angle like so, in which case, in our situation, it was crossing the path of the incisal edge. So when we put a hard object on the tangential surface of midfacial, we know that that's just not going to allow restorative space for the future restoration. And this is after several minutes of struggling and removing the implant, replacing it, maybe a little bit more osteotomy, how we were able to change the trajectory without losing the primary stability. So this photograph shows the difference that we have achieved. And do understand, because the bone is relatively soft in the maxilla, this is available and possible to perform in most situations. It just requires a lot of careful manipulation and the careful clinical skills to be able to do this without necessarily making the osteotomy site be so large the implant loosens. So as we can see, this configuration is how we are able to get that perfect distance with the incisal edge and therefore allow the biological materials to settle in the immediate gingival facial surface, which is critical for the long-term cosmetic and biological result. In my practice, I would routinely do cases like this with what we call the non-occluding implant restoration, basically a resin provisional screw retained that is out of occlusion and out of contact. However, due to the circumstances, we used a healing abutment, and we chose a long healing abutment for this purpose. I think there's something wrong with this image here because this is a 7 millimeter healing abutment, but the label says 2.5 height. It doesn't make any sense to me, but anyway, we chose this 7 millimeter very long healing abutment because we really wanted a tissue to get not submerged. We didn't want the tissue to collapse, so we put in a lot of biomaterials in the facial surface, but we didn't want the soft tissue to cover it either. This is not like a Son's Santa technique where we're trying to bring the bone up. I want a narrow healing abutment so it creates more facial space for the bone and for the sticky bone and for concentrated growth factor, but I didn't want any more than that. So here is a photograph depicting how we basically wedged the CGF into the sulcular area with multiple sutures. That is simply going to allow a nice seal and growth of epithelium over the open socket space without necessarily having to advance the flap and causing more surgical stress to the area. Here is the post-op PA showing the depth of the implant placement, which I think is appropriate, and eventually when we have a nice emergence profile, we should be able to get a very successful restoration with nice papilla retention and gingival form. So I hope that local partners should be able to complete this case with nice aesthetic result in a few months. This was a great case done by Dr. Tommy Park and his partner Jay Park. We had an amazing first day in Hanoi with these cases. So we had a memorable group come to this meeting, and every one of these people had a very great success. Here's my email just in case you need to contact me and ask questions, discussions, and so forth. Please feel free to do that. And until we meet each other again, good luck with your practices.